Hey guys, well, this is it. This is the last chunk of material for your exam 3. I have heard that Mr. Mortar has been powering through, which is pretty typical. Don't panic. He does this every year to every try. He'll go super slow in certain sections and then he'll just start motoring through material. So I have got notes for you through the end of the book because sometimes he makes it to the end, sometimes he doesn't, and sometimes he just tells you to learn it yourself. So this is a much more user-friendly way to get to the finish line, hopefully. All right, so we're going to start on page 224 with the head. And this is, again, repetition from a lot of that embryology material. So we're talking about intramembranous ossification versus endochondral ossification. And don't forget, if they're asking, if he hasn't already asked you a question about it on an exam, he probably will on this one. And the question will go something along the lines of, name which bone that undergoes both intramembranous and endochondral ossification. And that's going to be your clavicle. That's a classic national boards question. Pretty boring stuff. You know this. You've heard it a million times. So it's kind of a gimme at this point, but don't forget. Other things that you might want to recognize is forming true sutures, happens via intramembranous ossification, whereas false sutures develop via endochondral ossification. So more about those sutures. These are important to know. So there's that little table on the top of page 225. You want to know about these sutures. So we've got true or vera sutures and false or notha sutures. He normally just uses true and false, so I wouldn't worry too much about that. You want to know that the limbus are the overlapping and interlocking type suture. So I always think of like a pound sign or like a grid for limbus. And an example of that is the coronal suture. Then you've got your serrate suture, which is going to just interlock. So I think of like a serrated knife. Think of that edge on a serrated knife and what that looks like. And if two perfectly formed or perfectly matched serrated knives were butted up against one another, that's kind of what a serrate suture looks like. So the sagittal and the metopic suture are good examples of that. And then denticulate. So this one looks like, I've got some images, drawings, hand drawings on the next page, but it looks like very well spaced out teeth. So if you have like chiclets, think of all your fingers like chiclets, and then you put your fingers, interlock your fingers together. That's going to be what a denticulate suture looks like. And that's going to be your lambdoid suture. And then false sutures, you've got your harmonia and your squamous. So your harmonia kind of butt right up against each other. I just put your palms of your hands together. It's going to be a little bit like that. And then you've got your squamous, which overlap kind of like scales on a fish. The only thing you need to know about a Schindlisis really is that the sphenoid vomer suture is going to be an example of that. Sorry, joint. Sphenoid vomer joint will be an example of a Schindlisis. And then a gomphoesis. Gom makes you, should hopefully make you think of like mouth and gums. And so gomphoesis is going to be between your tooth and your maxilla. So your periodontal ligaments are going to be involved there. So if he's asking anything about the mouth, which sometimes happens, that's going to be your gomphoesis. So here's just some rough hand drawings of the different types, which I think makes it quite helpful. So there's a pretty good mnemonic for this stuff too. So you want to know the difference between your true and your false sutures. So so the mnemonic goes a little something like this. To go on a true trip, you take LSD. So true sutures, LSD, limbus, serrate, and denticulate. So to go on a true trip, you take LSD. And then for the false sutures, high school people are false. So HS false, and that's going to be your harmonia and your squamous. Yeah, hopefully that helps some of you remember. It helped me. All right, moving into the views of the skull. So you'll probably get a fill-in-the-blank question on one of these views of the skull. It's not the most interesting question, and a lot of it is really straightforward and intuitive, but some of it is just a bit of a drag. So here's your lists. So it starts on page 228. So your norma frontalis is going to be that view from the front. Just take a look at the list. I mean, look at your skull models and look at your stuff. If you have the little lab packet with the diagrams, the MASA study guide, look at that. So anything that you're seeing directly front on is going to be in that normal frontalis view. Occipitalis is going to be from behind. Hopefully you get that list because it's much more user-friendly than some of the others. Norma verticalis, so from the top, which sutures and things are you going to see there, and then lateralis, you've got your side. So he does like to ask, beyond those views from the skull, on the norma lateralis, you will almost guaranteed get a question from one of these, and it will be fill in the blank about which bones make up either the pterion or the asterion. So if you were in lab, and maybe your lab tutors have already done this for you, you remember asterion by you sit your ass on the pot. Asterion for parietal, occipital, and temporal bones. They come together to make the asterion. And then the pterion also has the parietal and temporal bones, but also the sphenoid and the frontal bone. So you could get either of those. Often it's the asterion, but I would know the pterion as well. I know how to spell both of those. It sucks, I'm sorry. Moving on, we've got the cranial vault capacity versus the skull size. So this is another fill-in-the-blank question that shows up all the time. So you want to know this. You want to know the features of the skull that allow you to determine the cranial vault capacity. And you also want to know the features of the skull that allow you to determine the skull size. So vault capacity is going to be your vertex, your inion, and your nasion. Be able to spell and write all those out. Skull size is pretty straightforward because it's all those three things, the vertex, inion, and nasion, plus the nantheon. Nantheon is super fun to say and super fun to spell. It's actually not that bad, but I would be prepared to do either one of those. So cranial vault capacity is just going to be where your brain is essentially, and then your skull includes your mandible. So that feature on the mandible. Okay, page 231 and 232. Any of these could be test questions. All of your openings in the skull and all of the things that go through them. So I just gave you a list. I'm not going to read it to you. I do recommend you take some time to look at it because you're going to have to do it in PNS anyways. So if you get a little head start on it now, it's not going to do you any harm, and it's only going to help you out for PNS. You have to know everything about everything in PNS. So definitely start now. Memorize, though I hate to say just memorize, but or find an association. If anyone comes up with great mnemonics or memory tricks, please let me know because I don't have any and none have been passed down to me. It's just kind of one of those things you have to grind through. Sorry about that. Oh, I guess I do have, so for the foramen rotundum, someone came up with this in my class, I believe. Someone said max is round. So foramen rotundum is going to be the maxillary division of the trigeminal. And then for the foramen lacerum, don't pierce the lace. So know that the internal carotid artery does not go through, does not pierce the foramen lacerum. Kind of goes in and back out again. It goes across it. So definitely know that. I believe the foramen lacerum was our exam question. But any of these are fair game. So know what the contents are and the opening. Scalp. This is a pretty awesome one because the mnemonic is just the word itself. So this is another common fill-in-the-blank question, believe it or not. So I would definitely recommend that you know all of this. So scalp stands for skin or integument. That's the outer layer. And then you've got the layer just deep to that, which is your connective tissue layer. That connective tissue layer is going to house all the blood vessels and nerves. Then you've got A for your aponeurosis, which is slightly deeper yet. Your muscles are going to attach there, so all of the muscles of facial expression are going to remember your gallia aponeurotica on the top of the head, so you're going to have a bunch of muscles attaching there to that aponeurosis. And then L, slightly deeper there, is going to be your loose connective tissue. And then finally, your P is your periosteum, which is that thin covering over the bones themselves. So definitely remember that the connective tissue layer is the neurovascular layer. It has the blood vessels and the nerves. A lot of people mistakenly put the loose connective tissue, but most of the blood supply is in that connective tissue layer, so just below the skin. And I always think of this because, you know, head injuries are notorious for bleeding like crazy. They don't even have to be that deep. Just below the skin, once you hit that connective tissue layer, they bleed and bleed and bleed and bleed and bleed. So that's where your blood vessels and your nerves are, and they hurt too. So yeah, that's the layer. Another fill in the blank question. I will explain the Zoolander reference in just a second. So, which facial muscles have no bony attachments? So these three muscles are all those facial muscles which have no bony attachments, and you often, almost always, have to use this as a fill in the blank question. So we think of the Zoolander blue steel look because those muscles actually have the actions that pretty much make that look a possibility. So when you think of muscles with no bony attachments, think of Zoolander, think of blue steel, do that puckered look. And then you've got your Procerus. He's a pro model, remember? P-R-O, Procerus, Rhizorius, and your Orbicularis oris. Zoolander's a pro. You got this. All right, so this is one of those things that I would have had you draw in your book during PASS and kind of explained a little bit. So we have on the left of this diagram is what makes up the walls of the orbit, and then on the right of the diagram is another eye which makes up the margins. So the nose is going to be medial, and then on the opposite side is going to be lateral on each respective side. So this would be one of those things that I would recommend you draw on the back of your exam if you were having in-person exams. He can ask a number of multiple choice questions on this regarding what makes up the superior wall or the medial wall or the lateral wall, or where certain fissures are found, so your inferior and superior orbital fissures in your optic canal. Or he can ask you which bones make up the whatever margin, the superior margin of the orbit. So we split that up because it makes it a little bit easier to digest, and you can just kind of look at one side or the other, but recognize that obviously there are margins on both sides and there are walls on both sides. So one that he super likes is the medial wall. So what makes up the medial wall is that lamina papricia. If you remember, I don't know, like grade school history or something, he talked about papyrus being used as paper. So lamina papricia is like a paper-thin, bony layer. And you would have to spell it in other circumstances. Any other questions are fair game. I believe we had the superior orbital foramen because it's on the lateral wall. So superior orbital foramen is on the lateral wall. And that can be a little tricky. So classically, that's a question. All right, question for you. What bone makes up the majority of the margin of the orbit? So when you're looking at the margins, frontal bone isn't 3 out of the 4 quadrants. So that's your answer. The frontal bone makes up the majority of the margins. So those are, I mean, that's just another question that comes up from time to time. So hopefully it comes up for you and then you know the answer right away. But again, this is one that I don't know, I would draw if I was taking a physical exam. Okay, more about the eye. So now we've got our external orbit features. So this is a really nice diagram of your eyelid. So we've got multiple layers that you want to know about here again. So you've got your skin, your muscle, remember that palpebral part of the orbicularis oculi, and then your tarsal plates. So your tarsal plates are going to be located on both the superior and inferior eyelids. So definitely know that. And then you've got your tarsal glands. Know that your tarsal glands are modified sebaceous glands. That comes up all the time. In the book, it's also known as a meibomian gland, so that might be important, but he normally calls them tarsal glands. He wants you to know that they're modified sebaceous glands. And then on the inner surface, you can see on the most right-hand layer of that diagram is going to be the palpebral conjunctiva. So the tarsal plate is what kind of gives your eyelid that structural support if you were one of those people who flipped their eyelids inside out. So that's going to be that tarsal plate. And your tarsal glands or your meibomian glands are going to be located in that tarsal plate. And I think that diagram on the right does a pretty good job of describing that. So hopefully that's helpful for you. And then nervous stuff. So this is a bit of a preview for your PNS class. So really everything that you do from this is just going to be helping you in PNS next try. Things that he likes to ask questions about are your parasympathetic versus sympathetic. So remember, your parasympathetic is your rest and digest. Your sympathetic is your fight or flight. So parasympathetic, when you're resting, your arteries dilate. There's going to be a lot of blood flow to the along those visceral efferent pathways, and your tears are going to have like a watery whey-like solution. So when your arteries dilate, you have more blood flow. There's more fluids coming to that region because it's not needed somewhere else. You're relaxing, you're watching a super sad movie, whatever it is that you're doing, you have watery. He likes the term whey-like. So if he says whey-like, I know most of us don't know what whey is at this point. And if you do, congrats. But watery, and I like to think of it like a really gross porridge. It just doesn't seem watery. Anyways, so sympathetic is the opposite. Sympathetic, your blood vessels and your arteries are going to constrict because it wants to direct the blood flow to the areas of the body that need it the most. So no crying during fight or flight. You're just going to get into action. So the best way to remember this, if you have any fear of public speaking, you know that sometimes you get up and stand in front of people and suddenly your saliva is incredibly dry. Everything's dry because your arteries have constricted. The solution is going to be significantly thicker, and that's that sympathetic response. All right, the eyeball. So page 240. You want to know the layers of the eyeball. So we've got our fibrous coat, our uveal tract, and our retina. You want to know the chambers and the lenses and all that good stuff. So your fibrous coat, it's going to be on the outside. It's going to be the protective layer, and that consists of both the cornea and the sclera. So the sclera, interestingly enough, is continuous with the dura, but both your cornea and your sclera make up that fibrous coat. Then you've got your uveal tract. So that's going to consist of your iris and your pupil. So the colored part of your eye and the hole in that colored part of your eye, because remember the pupil is essentially just a hole in that tract. And then you've got your ciliary body and your choroid. So this could be a test question for sure. You want to know your iris and your pupil, your ciliary body, and your choroid are all associated with that uveal tract. You also want to know that the uveal tract is the vascular part of the eyeball. So on that diagram on the right, you see you've got your iris, your ciliary body, and your choroid. Those are all part of the vascular tunic. So in this book, the vascular tunic does not, the diagram, the book is different. It does not include the pupil because, as I mentioned, the pupil is just a hole. But if Mr. Mortar asks it, he wants you to include the pupil because that was what he wrote in his book, and therefore it's what he cares about. then, as more about the uveal tract real quick, when we're talking about the parasympathetics, you want to know that that's going to activate the sphincter pupillae. So parasympathetic actually constricts the pupil. Your pupil is going to be smaller when your parasympathetic system is firing. And think of this like when you're relaxing. You probably talked about this in CNS if you went to Pass with Meanie. But you're relaxing, you're reading a book, you're just hanging out, and your pupil has to constrict so that you can focus on reading or whatever else you need to do. Your sympathetic, on the other hand, is going to activate that dilator pupillae. So your pupil's going to dilate. Like if you get freaked out, your eyes get really wide, you're able to see at distance a lot more and with a lot more peripheral vision, looking for signs of danger and all that jazz. So that's your uveal tract. That's the heavy hitter. I mean, you should know all this stuff because it'll come back again. Finally, your retina, that's going to be the part of the eye where there's actual photoreceptors and it's not continuous. It's just along the back of the eye. All right, so we have all this list, and this is a common test question and it messes a lot of people up. So what layer is the lens in? None. The lens does not belong to any of the layers of the eyeball. So definitely know that. Typically a true-false question, I believe, and just be confident. The lens does not belong in any of these layers. All right, chambers and lenses. So I would have had you draw this out when we were in Pass, but I think this diagram does a lot better than my really poor drawing skills. So you want to know the difference between segments and chambers. So segments are the big chunks of the eye. You got your anterior segment and your posterior segment. So this is where the lens comes in. The lens separates the anterior segment from the posterior segment. Then in the anterior segment, all of the fluid is called aqueous humor. And then in the posterior segment, it's all called vitreous body. So the vitreous body is really like a jello, like a thicker, more viscous fluid, whereas the aqueous humor is, as the name suggests, more water-like, more fluid, less viscous. So you got your aqueous humor in the front, in the anterior segment, and your vitreous body in the back, in that posterior segment. Then your anterior segment is further subdivided into two chambers. So you've got your anterior chamber and your posterior chamber. And the iris is going to be what separates those two. So fluid flows, it's actually created in the posterior chamber of the anterior segment by that ciliary body, which you'll get into more details about that next try. But it's created in that posterior chamber of the anterior segment, flows through the pupil, because remember that's just a hole in the iris, and it goes into that anterior chamber. So a buildup of that aqueous humor is going to be what causes glaucoma. But anyways, you should just go through these segments a couple of times so you have it very, very clear in your head, because these types of multiple choice questions can just be confusing in a high pressure type scenario, like in an exam. Orbital muscles, all right. So what you want to know about your orbital muscles. You want to know your origins and insertions. And then also your actions. You probably covered that a little bit more in the lab portion because they're a little bit wonky, some of them. Your rectus muscles are nice and straightforward. So they're going to originate from the common annular tendon, and then they insert into the sclera right in front of the coronal equator. So remember a coronal equator, think of like wearing, a crown or like a tiara. It's going to cut from front to back. So you can see how on the diagram on the right, we've got that lateral rectus muscle, and it's inserting directly in front of a line that would be cutting the eyeball in half from front to back. Which is why all those rectus muscles have really straightforward motions, because they just literally pull on the eye and the eye moves in the direction which it was pulled. Straightforward. Oblique muscles, on the other hand, those guys originate from the roof or the floor of the orbit, and then they go through their little pulley system, so their trochlea, and they insert in the sclera behind the coronal equator. So this is why their actions are really quite odd. So I think the easiest way to remember the oblique muscles is that know that both of them, both obliques, the superior and the inferior obliques, both act to abduct the eye, and then they also either elevate or depress opposite their name. So the superior oblique is going to abduct the eye as well as depress. So it's going to go down and out. And then the inferior oblique, remember those obliques are odd, so it's going to also abduct, but it's going to elevate. So it's going to go up and out. So hopefully that helps clear things up. I thought that was an easier way to remember it. Both of them abduct the eye, and then they also pull the eye in the opposite direction for which they're named, because they are inserting to the behind that coronal equator. It makes their motions a little more complicated than pull right, go right. Moving on to the innervation. So I hope you have all heard LR6, SO4, all over 3 before. So those are going to be that's the mnemonic for the extrinsic muscles of the eye. So lateral rectus is innervated by cranial nerve 6, superior oblique is innervated by cranial nerve 4, and then the rest of them are innervated by cranial nerve 3. So that's kind of helpful. And then another important point is that trochlear pathway. So cranial nerve 4 is going to be the only cranial nerve to cross over and innervate a contralateral muscle. So know that that guy is going to be innervating the opposite side from where it comes. And then we've got our intrinsic muscles. So we already talked about this a little bit previously, where we got our parasympathetic is going to affect the sphincter pupillae and constrict the pupil. Remember, small pupils when your parasympathetic's firing. And then also your ciliaris, whereas your sympathetics are going to dilate the pupil, so it's going to affect that dilator pupillae. Blood vessels. So really the big takeaway from this is that that central artery of the retina is the exclusive blood supply to the eye. So whenever you have any kind of neuropathy or increased pressure in the eye or increased intracranial pressure that causes pressure on that nerve, it's going to affect the blood supply, and because that's the only source of blood for the eye, if that's damaged, then you will go blind. There's no backup supply. So definitely know that. That's important. All right, so I didn't mention this before, but if Mr. Mortar hasn't mentioned it yet, he'll mention it soon. There are diagram questions on the final exam, and I don't know if you guys will have it, but I do tell people if you do have diagrams, because he's trying to make the exams as consistent as possible or as normal an experience as possible, then this is one of those possible diagram questions. And again, the MASA study guide's awesome for this. They're super straightforward because they're all things you go over in lab, so I hope you've gone over this a million times already, and it's pretty straightforward, and if not, I will try to help in any way that I can. So yeah, no like the sympaconcha, the tragus, the antitragus, the intertragic notch, all that good stuff. And then your external ear, so those muscles are going to be supplied by the facial nerve, and then you want to know the blood vessels. So this would be a typical multiple choice style question where you've got your occipital, your posterior auricular, and your superficial temporal. Those are going to be the blood vessels that supply your ear. Then moving into the external acoustic meatus. So you want to know the boundaries. That's going to be the concha of the auricle, and then it's going to go all the way to the tympanic membrane, so your eardrum, which is going to be the beginning of the boundary for your middle ear also. And you want to know about the ceruminous glands. Those are going to be the glands that produce earwax. They're also classified as a modified sebaceous gland, and they produce cerumen. So what kinds of glands were the tarsal glands of the eye? or the meibomian glands, if you will. Those dudes were also modified sebaceous. So interesting stuff. Two very different substances that are made by these modified types of glands. But just recognize that and you'll be good to go. Moving on. So your parotid region, that's starting on page 249. Pulling out the important parts, know about the retromandibular vein, know that it's formed by the union of the superficial temporal and the internal maxillary veins. That happens actually in the parotid gland, like inside the gland, those two veins unite to form that retromandibular vein, which, you guessed it, goes behind your mandible. Again, this kind of chunk of stuff would be super redundant if you'd been in lab, so hopefully he's doing a good job teaching you. That would be the kind of stuff I would recommend you review if you're feeling a little rusty on it. All right, moving on. The chorda tympani nerve. This guy is a heavy hitter. He shows up in PNS all the time. He'll probably show up on this exam, and then he's going to show up on boards again. Know that the chorda tympani is not going to be given off within that parotid gland. So it's not given off there, but it does travel through the parotid gland, and it goes to join with the lingual branch of the trigeminal nerve. So just know that it's not given off in the gland, but it does travel through there. And then again, parasympathetic does what the parasympathetic does. It's going to make whey like saliva, and there's a whole bunch of pathways. And then sympathetic, that's going to do the opposite. That's your cotton mouth, remember, thick mucus-like secretion. So real gross. But remember that your sympathetics are going to be firing when you're speaking in front of a crowd or recording yourself on a PowerPoint and you get cotton mouth. The TMJ, temporomandibular joint. Page 255. Remember, this is going to be a ginglinus type joint. And then you want to know a few things about it. Nothing too crazy. You've got your extracapsular ligaments and your musculature. So know that those extracapsular, so outside, beyond the capsule, they're going to attach onto the mandible. And then we've got the three different types. So the temporomandibular, again, those are two words that tell you exactly where it's coming from. So from the temporalis and the mandible, that go on to the neck of the mandible. Oh, sorry, from the temporal bone to the mandible, the neck of the mandible. Stylomandibular from the styloid process of the temporal bone to the angle of the mandible, and then the sphenomandibular, which goes from the sphenoid bone, the spine of the sphenoid, to the lingula. So I have that one marked as an NBQ, which I haven't taken part 1 boards yet because they've been canceled. But anyways, sphenomandibular is going to go to the lingula of the mandible. I think they like to ask questions about lingula. Musculature. So you want to know the functions of the musculature. So lateral pterygoid is going to be doing that depression, elevation. Just essentially know all of them. Know that, try to learn less to know more. So for example, I definitely memorized the fact that the temporalis is going to be the only muscle that retracts the jaw. So even just like clench your teeth and feel your temporal muscle, and you'll feel like as you're trying to pull that mandible back, like you're chewing or clenching your jaw, you can feel that temporalis flare up. So that's going to be responsible for that retraction. Every other muscle is going to act to protract the jaw. And then for depression, know that your lateral pterygoid is going to depress the jaw, and then suprahyoid and infrahyoid. You're good to go. All right, we're getting there. Got the pterygopalatine region. So know that the pterygopalatine ganglion is the largest parasympathetic ganglion in the head. And then I've got just that list of the visceral efferent parasympathetic pathway. So that's the order that it goes in. This is going to be more PNS stuff, so read it over. If you kind of get it, follow the path, you'll be fine. All right, for the external nose, nothing too crazy happening here. Most important take-home point is that that major alar cartilage does not have any attachment to bone. So sometimes that'll show up as a multiple choice question where he's asking you which of the cartilages of the external nose don't have any attachment to bone. So that's going to be the major alar cartilages. So if you flare your nose, that's your major alar cartilage. And in green on that diagram. All right, the mouth. This is another possible image question. He super loves the mouth. So if you have the Massa study guide or you have the diagrams that he gave you, that's great. Just go from that. Know about the frenulum and the vermilion zone and the vermilion border. So another classic test question is in that box on page 259. And you want to know that the vermilion zone and that pink lip color is unique to the human species. So only humans have that pink vermilion zone. Triangles of the neck. I know you guys have covered this in anatomy, so this is repeat, but these are just important to know. So you want to know what your boundaries are and what important things are located in there. So anyways, here's just a list for you. It's nothing too crazy. You can use your own body as your study guide and you'll be fine. Just kind of be able to trace out those triangles, know where you are in space. And yeah, that's it, guys. So this is the Kahoot for exam 3. And then this is the Quizlet for exam 3. So I have put pretty much everything that could be a potential TQ in the Quizlets, and I hope that you've been using them up until this point because I think they're super helpful if you're a Quizlet person. If you're not, I'm sorry. I know I didn't get to like the last page of the book, but really that's all. I mean, we're pretty close to the end. And then those muscles of the head, that last little section is just lab stuff anyway, so that'd just be a tad redundant. So hopefully that's helpful. Definitely go through the Quizlet. Let me know if you have any questions. Hopefully getting all this stuff to you a little bit earlier is helpful. And yeah, hopefully I'll see you in person at a club or something. Hope you guys enjoy the rest of your try and have a great summer break. Stay healthy.